بدأوا أستاذي الفاضل أستاذ دكتور أيمن فرغلي يكلمنا عن CTEPH The Journey.
السلام عليكم. It's clear from the topic I'm going to talk about CTEPH and the relation between pulmonary embolism, acute embolism, and CTEPH, and why not everybody developing pulmonary embolism is going to have CTEPH, and is it necessary to have CTEPH with a history of previous pulmonary embolism. So all these inquiries I'm going to discuss. Let's go through this case rapidly going. It's 42 years old man with recurrent PE. He has a history of air travel, long air travel. He developed pulmonary embolism, which was supposed to be provoked by the air travel. He has also a history of hypothyroidism. He has recurrent PE on February 2016. He was treated for 3 months and stopped treatment. After that, he has recurrence. CT has showing extensive embolic burden. Sorry. Echocardiography, he has mild RV dysfunction, heart rate was fine, no oxygen required, troponin, BNP were normal, low molecular weight was given, heparin, and prior venous thromboembolism, the only risk factor we have, negative thrombophilia, indefinite anticoagulation was planned. This is a history, patient who has embolism and recurrence, and this is the embolus in the CT angio, and it is in the center. As you see, you can differentiate between it and the chronic thromboembolism. We have to be very distinctive in this nowadays. It is in the center. This is acute thrombus. The right ventricle is still, it's fine, and the septum is not displaced. After 3 years, this patient came with progressive dyspnea, and this is the hallmark, dyspnea. The patient came with symptoms. On exertion, with insidious onset, with about 12 pounds increase in 6 months in his weight, and reported minor swelling of his feet. Chest radiograph, lung field were clear, pulmonary function test, mild reduction in DELCO, VQ scan, multiple unmatched perfusion defects. So the patient has multiple defects after these whole years, and he was referred to our to the pulmonary department. You can see the fan distribution denoting multiple defects in the VQ scan. And by the way, you should know that the VQ scan is more sensitive for chronic thromboembolism, vice versa with the acute pulmonary embolism. In acute embolism, CT pulmonary angio is a golden standard. But when you look for chronicity, you have to go with the VQ scan. So the patient was evaluated, and clinically has allowed P2, no murmur, and he was on medication, rivaroxaban and levothyroxine. In addition to the VQ scan, CT also was done and confirmed the presence of CTEPH. So this is a journey that usually comes, and actually here we have the echo, which denotes there is pulmonary hypertension, and now the septum is deviated. It's not as the original situation we have before. And we went to the right heart cath, and the right heart cath has showed that the pulmonary artery pressure is 44. Now the patient has chronic thrombosis and pulmonary hypertension, and the flag was raised by shortness of breath, dyspnea. Dyspnea should point to the chronicity of the disease, and we have to look for this patient in this way. The venous thromboembolism, and actually this is a preferred term. Venous thromboembolism means we have deep venous thrombosis with or without pulmonary embolism. And of course, the burden is well known. This is, for example, in the States, we have 200,000 deaths per year. We have over 600,000 patients diagnosed with DVT annually. And of course, it is causing mortality and huge cost. And it is increasing. So we need to be alert to the acute incidence. This is theories, and it remains to be the theories behind the thrombosis, stasis, hypercoagulability, endothelial damage, whatever the etiology. In addition to the risk of sudden death, 30% of survivors develop recurrence, 28% of survivors develop venous stasis syndrome. So what is the definition of chronic thromboembolism? Chronic thromboembolism is defined as persistent pulmonary artery pressure above 20, pulmonary wedge pressure below 15 at rest, at least for 3 months on anticoagulation. So the patient is going on anticoagulation for 3 months, and then he has pulmonary arterial hypertension. Patients that fail to meet the pH cutoff value of 20 millimeter yet have complaints similar to CTF. يعني patient symptomatic وعنده picture like CTF والبريشر قليل. ده category of patients محيرنا شويه دلوقتي، بنسميهم chronic thromboembolic disease. والconsensus up till now is to treat symptomatic patients. If he is not symptomatic, we follow up these patients. The optimal follow-up after acute embolism. Are we going to screen these people? Up till now, there is no consensus on screening. However, new or progressive dyspnea, exercise intolerance, and or impaired function or mental status after at least 3 months of adequate anticoagulation, you should be careful that we have some complication of the acute embolism. And this is called post-PE syndrome. And one of the most components of the post-PE syndrome is to rule out CTF in all PE patients with persistent symptoms. So to know whether this fresh thrombus is going to be this very rigid intimal proliferation, it's very important to have 3 months of treatment by anticoagulation, and then the patient is going to be symptomatic. The pathophysiology of CTF actually is not well known. However, it is a rare complication of acute embolism. The incidence is around 3 to 5%, characterized by fibrothrombotic obstruction. It is not anymore a fresh thrombus. It's poor prognosis. This patient usually, if left without treatment, they die within 3 to 5 years, depending on the level, of course, of the pulmonary artery pressure. However, a number of treatment options are now available, and this is actually what happened in the last few years. Management of CTF has advanced, and actually we have different modality of treatment. The best is to do endarterectomy if the disease in the proximal arteries. If it is in the mid-sized arteries, now we have the balloon bronchoplasty, which can be done, and at the end we can have medical treatment. And actually we have now the 3 modalities done in Egypt. I'm so proud to have this, and actually we have a very good team evaluating these cases, and we have very good results, in fact. So this is the distribution. We have a proximal pulmonary artery fibrotic obstruction. We have distal pulmonary artery fibrotic obstruction, and the microvasculopathy at the end. The incidence, as you see, it's different due to difference in registries. However, it's varying between 1.7 to 5.7 per million adults. Between 300 and 400 patients were newly diagnosed in France and Germany. Pooled incidence of chronic thromboembolism in 3 predefined patient subcategories. So the numbers are like this. In all comers with PE, it is around 0.5%. In all survivors, it is around 3%. And again, in survivors without major comorbidity, it's around 3%. That's why screening is not recommended up till now. Not everybody developing acute embolism are going to follow him and look for CTF. Only the patients who develop symptoms after completing treatment, I'm going to pick this patient and we do right heart cath for them, and also echo before. Thrombus non-resolution. Why in some people the thrombus does not resolve? This is a mystery. So they started to look. These are the risk factors for patients to develop CTF. And actually, this is statistical. It is not correlated pathologically. So factors specific to the PE, for example, if it is recurrent or unprovoked, patient developing CTF without previous embolism. Large perfusion defects from the start, estimated systolic pressure above 50 from the start. Patients who have high pulmonary artery pressure from the start, this is not totally acute. There is something behind. Persistent pH on echocardiography 6 months or actually 3 months after treatment. Thrombotic factors, people who has lupus, antiphospholipid syndrome, actually these people are condemned. Chronic medical condition like infected ventricular atrial shunts, splenectomy, chronic inflammatory disorders, and of course cancer. And some genetic factors, it was related to the ABO blood group O and abnormal endogenous fibrinolysis. So these people, we must phenotype these people and look specifically for them, they might develop CTEPH. Incomplete resolution is not rare. Some studies reported that persistent lung perfusion in 50% of cases after 3 months of anticoagulation, but they are not symptomatic. So if you do thorough investigation, however, these patients are not presenting and are not symptomatic, and actually they are not going to develop the full-blown picture of CTEPH. Screening, as I told you, in view of the low incidence up till now, because you know screening is cost benefit. Is it cost effective to detect these 1.5 or 3%? Actually, up till now, it is not recommended. So you have to look for patients who are symptomatic. Of course, there is some insufficient awareness, and evaluating the index imaging test used to diagnose acute CTEPH and echocardiography is the preferred first line. Can we say we have CTEPH from the start, from the radiology? Yes. These are the criteria in the CT, and this is the criteria in the digital subtraction angiography. And simply, if you have this mosaic appearance, be careful. This might be CTEPH, mosaic appearance. This is not an interstitial lung disease. If you have some peripheral shadows like this might be healed infarcts. Again, healed infarcts. If you find the thrombus lying on the wall, this is a sagittal thrombus. It is not acute embolus. So be careful about this patient. Of course, the whips and the cutoffs are also very characteristic for chronicity. If you find tertiary veins and the collaterals, this denotes that we have a long-standing obstruction, and this is a CTEPH. So these some signs that in the radiology that can tell you that you might have. So some people ask, we didn't treat the acute embolism properly. That's why people develop CTEPH. And actually, the data came and say, no, high quality anticoagulation did not prevent CTEPH. So there is something inherent in this patient that predisposes them to develop CTEPH. Even with thrombolytics, people, there is no proof that aggressive treatment with acute pulmonary embolism can prevent CTEPH. So CTEPH actually is a syndrome, and there is some mysterious things behind, and it might be having some remodeling process akin to that what's happening in the idiopathic pulmonary hypertension. From animal studies, we have learned that the issue is not at the point of obstruction. We have some vessels obstructed. However, there is some reaction due to cytokines circulating to the other normal vessels. And there is some vasculopathy. And the vasculopathy, there is some theories for this, maybe angiogenic factors, chronic inflammation. And also there is some functional changes like nitric oxide and the endothelin receptors potentiation. So we have some pathogenesis, which is akin to idiopathic pulmonary disease, and this can illustrate why it is a multifactorial disease. So this is a pathogenesis in CTEPH. We might have distal thrombosis of the pulmonary artery with partial canalization. However, PAH-like lesions and the muscularite arterioles are there, and even the capillary at the capillary level, it's a kind of capillary hemangiomatosis, and even in the venular level. So it is a complex syndrome, and CTEPH is dangerous, in fact. Some people are inoperable, and actually when we have an angio like this, and we find the periphery is pruned like this, we are not happy because it means he has a small vessel disease and nobody can reach them with surgery. These are some risk stratification for the surgeons before they do endarterectomy. They can أنا عندي سلايد واحد لو تسمح لي أقوله. We can tell that this patient is critical or not from this data regarding the history, the examination, the comorbidities, of course, functional class, imaging, type of disease. If it is bilateral lower disease, it is easier. And the pulmonary vascular resistance is very important. If it is above 1,000 dynes, it means it is a serial case, and this patient has a peripheral disease. These are some studies that have been done to predict peripheral diseases, and actually this is a right heart cath curve, the transition from the pulmonary artery to the wedge. This is a pulmonary artery pressure to the wedge. If it is steep like this, it means the vessel is patent, the peripheral vessels are patent, and we can go for surgery. If it is very slowly going down, you mean that you have a lot of small vessels obstructed. The coupling has been talked about by Professor Youssef, and this is pathophysiology again. Let's go for our take-home message. Current understanding of CTEV has moved beyond a chronic obstruction caused by unresolved thrombus to a multifactorial disease. So we have obstruction, small vessel disease, and remodeling. Inflammation and infection are condemned, and actually further research into small vessel disease in patients with CTEV actually is very important, because these patients are not only due to obstruction, there is a syndrome, it's going on. Thank you very much.
Thank you so much, Professor Ayman. As usual, سهل ممتنع.